All right, so we're going to spend this noon hour talking about practical approach to neonatal brain imaging. And I think this is very important because I am trained in both adult and pediatric neuroradiology, but what you see is that you either have a very specialized practice, freestanding children's hospital, or you have an adult hospital with, a smaller kind of associated children's hospital, maybe a NICU. And so you get some of these babies that are born and occasionally will get imaging. And even if they are later to be transferred to a more specialized center, you do end up being responsible for interpreting them. So I wanted to provide, just based on my career, some of the key insights and hopefully make it simpler for everyone to understand from a mechanistic standpoint. Okay, so today we will review the general principles for neonatal clinical care and imaging. I will show classic examples of preterm and term brain injury. That's what you would see in all the textbooks. So I'll try to make it a little bit more straightforward mechanistically. And then we're going to mention a number of special diagnoses that have characteristic imaging features, things you don't want to miss that do have more unique features that can actually help you understand the diagnosis. Okay, so let's start with the basic principles. So, from an epidemiological standpoint, in the United States and developed countries, about 10% of babies are born preterm. Now, there are varying levels of prematurity, but approximately 1 in 10 babies. And then 1 in 3 out of every 1,000 live births suffers from hypoxic ischemic injury. So, this could be difficult delivery, placental abruption, and so forth. And in undeveloped countries, the incidence is higher. It's around 11% preterm and up to 30 or more per 1,000 live births. So these conditions have a high morbidity and mortality for a couple of reasons. The primary insult essentially hits what we call the selectively vulnerable structure. So essentially, in these early phases of neonatal development, there are certain immature structures or maturing structures that are developing. And so if you have a hypoxic and or ischemic insult, those will be selectively hit, right? So you'll see these imaging patterns that are unique to the neonate and not seen in older children or adults. And maybe even more importantly for prognosis, there are secondary and tertiary delayed injuries that essentially are metabolic inflammatory cascades induced by the primary insult. And the tertiary effects on neurodevelopment can actually persist for months or even years out to school age or adulthood. We can see, for example, impact of extreme or very preterm birth. So the outcomes, there's this term called cerebral palsy or CP. It's kind of a bucket, wastebasket diagnosis. And so it can mean many different things, right? And it's not always, although it's clinically diagnosed, on imaging, it can actually reflect many different things. So in terms of the clinical definition, they are disturbances of movement and or posture. There are different subtypes. The spastic, which is stiffer, usually associated with more white matter injury. The dyskinetic is abnormal, uncontrolled motions, and those that are typically more gray matter injury. And then ataxic imbalance, which is often cerebellar injury. And obviously, you can have mixed subtypes. But when you look at imaging, there's all sorts of preterm, term birth injury. Genetic diagnoses actually is now up to a quarter of them, unsuspected genetic malformations. So again, it's a very loose term that's used clinically and really can lead to a lot of different imaging manifestations. And then importantly, and we still don't understand this completely, but how do we intervene and optimize these outcomes, right? So obviously modifying risk, any risk for preterm birth, any risks in terms of the extended or difficult delivery, and then neuroprotection. Can we modify and decrease the burden of delayed injury, right? These secondary and tertiary injuries on top of the primary insult. So as a radiologist, like it's actually very important, and even more so in this perinatal, neonatal period to know the clinical history, because there are many different factors that can lead to kind of a final common pathway for injury. So you want to look in the note, and if you really need to actually contact the clinician, ask, get whatever information you can about prenatal history, what was the fetal course? Did they have regular checkups, right? Was anything detected? Maternal things, gestational diabetes, preeclampsia, all of these things that might affect the health of the fetus. What was the gestational age at birth? Were they premature? Were they term? And then postnatally, what was the delivery course? Was there an assisted delivery? Was it a normal delivery? Was the baby requiring resuscitation or support? What were their APGAR scores? Were they looking a little blue? And then afterwards, what testing was done? If they're in the NICU, what are their labs? What might that entail in terms of metabolic disruptions and whatnot? So let's talk a little bit about gestational age. Preterm, by definition, preterm birth is anything less than 37 weeks since the last menstrual period at the time of birth. And we round down to the last completed week. So even 36 weeks, 6 days would be considered a late preterm. Obviously, very mild, right? But that is technically preterm. And so the more preterm you are, the more immature these structures are, and the more likely you are to have brain injury, multi-organ injury, and long-term complications. Term is anything, between like 37 to 41, but full term technically is the, around the 40-week period. You could be, early term or late term. There's also post-term, so 42 weeks or higher. And this is also associated with complications, oligohydramnios and placental, degradation and so forth, and macrosomia. So typically they will induce a pregnant lady if she goes beyond 42 weeks to avoid that. Okay, so the term neonate officially means up to 28 days after birth, no matter gestational age. Colloquially, they also call this the newborn period, although that's a looser term. Infant is up to 12 months, right? The term baby is also used generically, but some people will use that for a wider span up till they're walking. And now let's talk about corrected age. So if you're preterm, right, then you're actually going to be behind on your milestones. So you can't use the normal pediatric milestones like walking, rolling, right, because you're actually behind. So let's say you were born at 34 weeks, right? So you're actually 6 weeks behind from a full-term baby. So you need to actually correct for that prematurity when you look at the milestones. So until at birth, they're actually -6 weeks, right? And so not until they reach 6 weeks chronological age after birth will they actually catch up with the full-term baby in terms of milestones. So that's the idea of corrected age for prematurity. Okay, so imaging modality. So in the neonate, we often start with head ultrasound because it's, there's no ionizing radiation, it's fast bedside exam. And so they can go through various fontanelles, which are essentially these, like open, non-ossified fibrous things in the skull that actually the sutures and fontanelles are there because they can mold as the baby goes through the birth canal, right? So you have some level of plasticity. And then as the brain grows, it keeps the sutures open and they start to narrow and fuse over time depending on age. So the anterior fontanelle actually stays open, till about 14, 18 months of age. So obviously throughout the infancy, you can still insinate through it. And so you can see in the coronal and the sagittal plane, the ventricles, nice gray-white distinction here, the corpus callosum, the cerebellum, if you're lucky as well. We don't typically do CT, because of the ionizing radiation, but let's say if there's a trauma, right, accidental or non-accidental, any concern for, hemorrhage, for fracture, rapid screening, if MR is not immediately available, that might be within the risk-benefit ratio. And so here, you can see that the neonates have waterier brains than adults, right? Because they're not myelinated yet. And so it is a little bit more hypodense here, and that's normal. And the overall volumes are fuller too, right? So unlike the atrophy you see in the adult brain, right, you actually have a relatively smaller ventricle subarachnoid spaces for much of the infancy, childhood. Now you can have the so-called benign enlargement of subarachnoid spaces transiently, around 9 months or so, and self-resolving around 2 or 3 years, but not in the neonate. And then you have these sutures, right? The sutures and fontanelles that I mentioned. So these are going to be pretty open and maybe a little overlapping if they had a vaginal birth, right, going through the canal there. And then they actually narrow pretty rapidly in the first month or so. So then you have a couple millimeters, and then they steadily narrow over time and have different age-related times of closure. So for example, the metopic suture in the front here closes earliest, can be 4 months or sometimes even a little bit earlier. And then we have MR, which is really the workhorse for all of our problem solving. So I want to show you this because this is what a normal term neonatal MR should look like, right? So I have these arrows here on what are called the posterior limbs of internal capsules. So you've got the anterior limb, the genu, the posterior limb. And so you see that that's pretty much the only part of the neonatal brain that's myelinated, right? Because what do you have to do when you're born? You have to cry and reach out for mom, and that's pretty much it. So this T1 shortening myelin is fat and protein, right? So you're going to get T1 bright, T2 dark kind of signal here. And so it's pretty much that posterior third to posterior half of the pelic or the plic should be myelinated if you're a full-term infant. Obviously, if you're preterm, it might be a little less. But if you're not seeing it at all or barely, then you have to be suspicious that maybe there's something obscuring it, right? Like maybe an edema from an hypoxic ischemic injury. And so here, this is the apparent diffusion coefficient map from the diffusion. And so there's nothing restricted. That's as it should be, right? This is a perfusion, what we call arterial spin labeling. And so you see that, again, right, the basal ganglia are the most robust and the corticospinal tract. So they have good flow because they're actively developing. As a result, because they have more flow normally, if you have a hypoxic ischemic insult, they will be selectively vulnerable to a severe HII because they are taking more blood flow at baseline. But still, the rest of the brain does have, a reasonable flow. It's just not as much as the actively developing myelinating areas. So that's important too. And then MR spectroscopy, another advanced tool, right? So we can do voxels. Usually they'll do one over the basal ganglia, like a single voxel, one over the white matter. And then you can basically get the different metabolites. This here is a long echo MRS. And so we're just cleaning up the baseline here, essentially just looking at the major metabolites. And so again, in contradistinction to adults where they have that Hunter angle that's supposed to go up, right? So your NAA from your neurons is higher than your choline from your cell membranes. Well, the infants are still, they have some anaerobic metabolism, even more if they're preterm, but basically at term age, right, they still are undergoing a combination of aerobic and anaerobic. So the NAA area under the curve of the NAA peak, right, is around like 2/3 of the choline, and that's actually normal to have that slight downslope. They can have a little bit of lactate and lipid, again, because of that, some of that physiologic immature anaerobic metabolism. So that's actually what a normal MRS looks like, and that'll be important for us later on. Okay, so MRI considerations. In babies, right, they have to be stable before they can go down for MRI. So if they're, difficult delivery, they have all this like support devices that are MRI incompatible. Maybe they're preterm and they have this, huge surface area to volume ratio, so they're losing heat, right? So you need to incubate them. They also sometimes like to move like any patient, right? So you might have to do the so-called feed and swaddle, right? So that they get postprandial and then you can like wrap them up real tight. Sometimes if they're still moving and it's important that you get that detail, you might need to do sedation or even general anesthesia, depending on how suspicious you are. Obviously, we don't love to give general anesthesia to kids below 2 or 3 years of age because there's some literature showing that there's long-term neurodevelopmental effects, right? But again, it's all about the risk-benefit ratio. Okay, so then imaging-wise, right, you have to decide what kind of scanner you want to use, right? The standard ones are 3T and 1.5T, of course, and 3T gives you much nicer brain detail. You can do more with the advanced imaging, but there are a number of emerging platforms, low field, more accessible MRs, which slightly lower image quality, less capability for advanced imaging, but some of these are self-shielded, right? So they can actually be on the floor in the NICU, right? And even if they have some lines and tubes, they may still be safe enough to not, deviate within the scanner. But obviously, you need to work with your MRI safety people and do testing and all of this because these are more non-standard devices. But the idea is that if you're not the baby's not stable enough to be taken all the way down to radiology and MRI, some of these units are kind of more point of care and may allow for more real-time scanning. And then obviously devices, if they have support lines and things like ECMO is a big no-no, right? You have a lot of deviation in the vessel and stuff. But some of the other lines and tubes, depending on screening and compatibility, gold EEG leads can be scanned in MRI. So it just depends on what they have and whether those things can be taken out or switched out for MRI compatible or conditional ones. And then what sequences, are you just doing like a basic screening and rule out, or are you looking for high level migrational anomalies that you need like that really good advanced imaging? You want to run some advanced sequences. So again, that all kind of relates back to sedation, anesthesia. And then contrast, again, like a gadolinium deposition in children, even the macrocyclic agents have a little bit of that, and the babies have a very immature blood-brain barrier, right? So we don't know what the long-term effects are. So typically we are not going to give contrast unless there's a tumor or infection concern, right? And then, of course, in those cases, you can. And then timing. So that's the kind of the biggest pitfall, right? Is that the findings of the neonatal brain imaging depend very much on the timing after birth or after the insult. So some places, not too many, a minority do immediate imaging within the first 1 or 2 days after birth. The reason that a lot of places don't do this is because I'll get to it later, but they often will do cooling or other, supportive therapies, and so that kind of gets the baby out of circulation for MRI compatibility. So there are places that do early scans within the first, let's say, 3 to 5 days. There are places that do later scans within the first like 1 or 2+ weeks, right? Or at the time of discharge. Some do both, and then of course follow up after discharge when the baby's older. And each of these has pros and cons, right? So it's actually incredibly heterogeneous practice variations across the country and across the world. And so I'm going to just talk about all of the different possibilities kind of at a high level. But if you look at the major, clinical trials and landmark publications, most of them are talking about either early and or late imaging and comparing the two. Okay, so normal myelination, we have to know about normal before we can diagnose abnormal. So I talked about this a little bit in that other slide, but essentially myelination happens starting in about the fifth fetal month, and it starts in the peripheral nervous system, and then it goes in kind of a stereotyped direction. So it'll actually go up from inferior to superior. So we'll go from the peripheral to the spinal cord, brainstem, right, brainstem cerebellum, and then starts to get into the supratentorial just at the time of birth. It tends to go from central to peripheral, right? And then also, generally speaking, posterior to anterior, so that the frontal lobes, the executive areas, myelinated last. But also the eloquent tracts will myelinate earlier. So like I said, those corticospinal tracts and the plics, visual cortex, sensory-motor cortex, areas that you really need to use, right? The babies are going to mature those faster. And so myelin is fat and protein, right? So again, at birth, right, you just have the plics that are involved, T1 bright, T2 dark. And then over time, so there's a saying T1 at 1, T2 at 2, right? So the idea is that by 1 year of age, you have essentially inverted the contrast. So you have enough myelin on board to have white matter being white on the T1, just like you'd see in an adult, even though it's not complete yet. And then it takes another year, so about 2 years of age, where you actually get the full T2 hypo intensity out to the periphery to have the kind of adult pattern. So you can date, myelination on T1 up to 1 year of age and then T2 up to 2, assuming they don't have some kind of genetic or epilepsy or something that would slow myelination. Flare, so that's kind of like macroscopic suppression of fluid. And so when you have intramyelinic edema that you're looking at, so why is it T2 dark? Basically, you're forcing out, as you myelinate, you force out the free water between the layers of the myelin sheath, so it looks dark on T2. But flare is looking more like macroscopic collections, right? So the picture is actually very confusing in neonates and young children. And so I can always tell if a place is like a serious children's hospital by whether they ran flare on kids less than 2 or 3 years of age. It's just not helpful in most cases. Maybe like tumor infection, if you wanted to do a post-contrast flare to look at superimposed edema, leptomeningeal disease. But in general, like doing a pre-contrast flare in young children really is kind of a waste and can actually cause more confusion. So diffusion pitfalls, just like in adults, right? If you're not doing in the first few days, which often happens because you're cooling them and stuff, or they're not stable, then it could pseudonormalize, right? So pseudonormalization happens like around a week. So timing is one thing. Also the gradient, so what we call the B value, the gradient strength. So babies are less anisotropic because they're not myelinated, right? So in adults, we typically do B of 1,000 as a standard. But in kids, we often do B value 700 or 800 because they're more watery, right? There's nothing to measure. You can go higher. You could go to let's say B of 2,000 and you could exaggerate the contrast, but you could also overcall, right? Because you might be exaggerating the normal physiologic contrast. And if you're not familiar with that appearance, you might overcall ischemia. And you can also do synthetic gradients. So I recommend that, honestly, because if you already have two B values, 0 and let's say 800, you can essentially generate other synthetic ones if you want to just exaggerate contrast without trying to overcall. Temperature is also an issue, right? Because water molecules diffuse more slowly at lower temperatures, right? And more fast. So if you're cooling you're going to, again, potentially overestimate the level of restriction. And then as you rewarm, that pseudonormalization may actually be stretched out in terms of time. So these were all kind of like in the middle time period, like maybe like around 5 to 7 days where we did diffusion. And as you can see, this one has only one spot, but it was a moderate HII. It's just that a lot of it had pseudonormalized by then. This was a MCA large vessel occlusion, but only the lenticular striates are like, fully restricted. The rest was partially pseudonormalized. And then these areas again, so if it's a severe insult, right, moderate or severe, you have ongoing injury at day 5 to 7. That's pretty bad, right? Because normally the diffusion stuff comes down and starts to pseudonormalize after 4 days. So if you're still seeing diffusion restriction, even if you're only seeing like a little spot, but the fact that you're seeing it later on means that you're probably dealing with a more serious insult, if that makes sense. Okay, and then spectroscopy. So there's this saying that spectroscopy is all something for the future, right? It has a lot of potential, but it never seems to quite hit it in clinical practice. I mean, the babies, if they're moving, right, you have this big voxel and a small head, and then there's a lot of variation between scanners and things. The tips I want to give you, so a short echo is good for metabolic disorders, right? Because it's shorter, so you have a noisy baseline, but you can catch small metabolites, right? So like things that you might not be able to detect once you have a longer echo and you clean up the baseline. So if you're looking for metabolic disorders, do a short echo. Long echo takes a little bit longer, cleans up the baseline, so you just get the major metabolites. So if you're just trying to grade HIE, then do just the long echo, because you really are just concerned about the ratios. And then the 144, the intermediate echo, like that's really just academic, right? The idea is that because of the J coupling of the methyl group on the lactate doublet, right, that you could invert below the baseline if you had a lactate peak. But honestly, this is really obvious. If it's a big lactate doublet, it's not going to be diagnostic dilemma. So why would you waste time doing another one unless you want it for a talk or something? And then if it's a small one, right, if it's a small one that like you're questioning like a mild lactate peak at short echo, by the time you get to longer echo, it will have decayed, right? So just because you have a small doublet and you don't see it invert because it's all noisy in here at intermediate echo, it doesn't mean it wasn't lactate. Basically, if it's a narrow thing at 1.44 parts per million, like I would call it lactate, right? It doesn't matter. Like I don't see the point of doing this in general. And then evolution-wise, right, again, depending on the nature of the injury, right, you can see, like, for example, this patient had progressive HIE, secondary energy failure. So day 4, day 7, day 10, you see the lactate and lipids coming up. You see the NAA coming down, right? And so basically, this neonate was having progressive injury metabolically, right? But again, we never interpret these in isolation. It's always in conjunction with all of the basic anatomic imaging. Okay, so let's go into classic cases. So preterm brain injury. So there's a couple classifications of preterm birth clinically. So indicated as an iatrogenic. So the mom had preeclampsia, right? There was, rupture of membranes or something. And basically the child has to be delivered. There's no choice. Otherwise, to keep them, in utero would cause more harm. And then there are spontaneous ones, right? So for whatever reason, genetic or some environmental thing, maybe lifestyle, it's smoking, whatever. For whatever reason, the preterm birth just starts spontaneously. And it's really a cascade of vascular and/or inflammatory factors that leads to this that we're still really trying to understand better. And the problem, of course, with preterm birth is that you have many immature organ systems. The neuroglial precursors are all immature. Birth is a traumatic event going from in utero to ex utero. And so you have these, friable vessels and other things that are being damaged with the primary insult and then also secondary and tertiary, right? So you're getting ongoing destruction cycle and then long-term dysmaturation. Therapy, so they have tocolytics to try to slow down delivery, and then just things to help decrease inflammation, reduce infection, keep the small child warm, keep them ventilated, right? And then the big one for preterm is this kangaroo care, which is, what's kangaroo care? So it's basically like skin to skin contact between the mother and the baby. So it helps both of them, right? It helps with the bonding. It helps with like microbiome and, breast milk and stuff so that this neonate is getting like a lot of the kind of protective factors from the mother that they have lost from being the preterm birth and so forth. So the idea is like this tree kangaroo, right? Is that basically, if you look at a newborn kangaroo, is this tiny pink hairless thing, and it has to crawl its way up to the pouch and like find the teat. So honestly, like humans have it a lot easier because we have all this exogenous support. But yeah, that's the idea, right? So basically it has to sit in there and mature and have skin-to-skin contact. Okay, so preterm brain injury imaging. So they're going to have an immature brain, right? So less sulcated, less myelinated than a term infant. There are certain characteristic patterns we see with preterm brain. The white matter injury, right? Because the white matter is still developing. You can have punctate lesions, punctate white matter lesions. You can have diffuse excessive T2 hyperintense signal, just like all the white matter is kind of a little bit edematous. You can have the so-called periventricular leukomalacia, where you actually get cystic degeneration in these watershed areas around the medullary veins that are draining. Intraventricular hemorrhage, so this is the papule, classic ultrasound classification. And what I wanted to point out about the IVH grading 1 to 4 is that it's actually a progression, right? So you have the germinal matrix gives rise, it matures and migrates, right, and forms your neuroglial structures, but it involutes, it migrates and involutes by like 35 weeks, right? So basically the last place that it involutes at is the caudothalamic groove. And so in a mild preterm birth, right, that's what you might just see the grade 1 hemorrhage in the caudothalamic groove. Grade 2 is when you actually have intraventricular hemorrhage. It could be some layering blood products, or it could just be some ependymal hemosiderin staining the lining if it's already resorbed. Grade 3 is when you have ventriculomegaly, right? So now you're actually clogging some of the outflow tracts. So you're actually getting some hydrocephalus. And then grade 4, they talk about parenchymal involvement, but it's not just any parenchymal involvement, because some of that could be white matter injury if it's distal. It's the idea that the clot is actually occluding the medullary venous drainage enough that you're getting a medullary venous infarct around the periventricular white matter. So it's a direct result of having clot like clogging the drainage pathway. So it's actually a progression. I'll show you examples of that. And then cerebellar hemorrhage, often under-recognized, but really important because preterm birth really has a lot of long-term cognitive effects. And we've come to understand in the last decade or so that the cerebellum is not just responsible for balance, right? There's a lot of like higher level cognitive executive function. And so that relates again to that kind of long-term neurocognitive effects of preterm birth. And so there are infrontatorial external granule cells, which are kind of the analogs of the germinal matrix that are migrating out, and those are also susceptible to injury. Okay, so timing. People do not recommend MR for early, preterm birth because, it's going to be abnormal, or it's going to have some of these findings. So ultrasound for screening is fine. And then if you see something, floridly abnormal, you can get an MR to confirm. But again, that just kind of tells you about etiology. It's going to be abnormal if they're premature. The term equivalent, so basically once their corrected age is like 40 weeks, like before they're about to be discharged and they're stable, that's been much more successful in the literature for predicting long-term outcome because you're looking at the complications of the original insult, and it's better for prognostication. So, and they're going to be more stable for imaging as well. So if you had to choose one, generally speaking, it's better to do term equivalent. You can do early, but again, that's more for just understanding. Okay, so preterm ultrasound has, different manifestations, right? So you can have some of this kind of periventricular white matter injury. You could have this grade 3 IVH with the caudothalamic, an intraventricular hemorrhage and hydrocephalus, and you see that echogenic kind of debris along the ventricles. So normal germinal matrix can also be echogenic, but it's very well defined and curvilinear, and you're not going to get that extra debris and distension. And here's a grade 4 intraventricular hemorrhage, right? So now you have so much clot, right, asymmetric here, that it's actually plugged up the medullary veins, and so you have this radiating periventricular hemorrhagic infarct. So the ultrasound echogenicity is tricky because it can be like a little bit of white matter injury, it can be some mineralization, it can be hemorrhage, right? So be a little careful because many things can look echogenic, right? But it's really looking at these secondary signs as well. And you see that all of these have like this kind of immature sulcation pattern, right, of the preterm infant as well. Okay, so at MR, right, preterm intraventricular hemorrhage. So this is that grade 1 caudothalamic groove, grade 2 in the ventricle. And you see it's not just that layering, but you see that on T2 or susceptibility, you see that kind of like dark line, right? That shows that you had hemorrhage. Even if it's completely resorbed, you can still see that siderosis. Here's grade 3 with some distension and shunting. And then here's that grade 4 where you're clogging up the ventricles, and now you have that periventricular hemorrhagic venous infarct. And then the late complications, right? So this doesn't just stay like this, right? Basically it involutes. And the term porencephaly, it's a white matter, relatively clean line cyst because again, in neonates, they have very immature glymphatic system. So the astrocytes are these glial cells that cause astrogliosis, right? So the scarring after injury. And so those things are not mature until the first couple years of life. So when you get an injury like this, as opposed to an adult, it can be a very clean cavity. And so that's porencephaly. So basically these things can involute, you can have siderosis, you can have transmantle porencephaly essentially, so that you have almost no residual cortical mantle. And then you can have the dreaded complication, which you see in many preterm infants of the post-hemorrhagic hydrocephalus. You get all these adhesions, post-hemorrhagic adhesions, and isolation of the ventricles, and it becomes very difficult to manage their hydrocephalus because you have so many different loculations in here. The white matter injury, so early, so again, like there's obviously interventricular hemorrhage on board here, but you see these separate areas of like little hemorrhagic, and these are not next to the ventricle. They're not caused by clot, right? So these are actually separate areas of white matter injury with blood fluid levels, with this T1 shortening of dysmyelination, cystic, and so these little areas, right? So in the watery brain, it's going to be baseline white matter is unmyelinated, so it's going to be T1 dark, T2 bright, right? Edematous brain. And so on that background, you can see little areas of white matter injury or dysmyelination with this kind of excitotoxic insult, right? Mineralization with this T1 bright, T2 dark signal. And the T2 stuff is kind of more variable because it's kind of already watery, so it can be a little hard to tell, but the T1 can actually be very, very helpful. And then late findings. So if you just see this kind of like patchy, periventricular white matter stuff, and there's volume loss, right? You suspect, right? Even if this is an adult, right? And you're reading it, that you suspect that they had some preterm white matter injury. When it's more profound, they actually have this angular morphology. It's the draining medullary veins. So they kind of have this triangular shape to them of the watershed, and then angular extravascular of the ventricles. And here's the cystic periventricular leukomalacia, so actually cavitating now, but again, that kind of periventricular watershed. And then here's one with like porencephaly and adhesions and very, very thin cortical mantle, a lot of white matter predominant volume loss. All right, and then we have cerebellar hemorrhage. So again, this can be on T2 or susceptibility, but you see these areas of, dark signal, and you can have like a few foci or several, or even like diffuse throughout the cerebellum, leading to, hemorrhagic infarct and hypoplasia and so forth. So in the long term, so this is an ultrasound here, you can actually see this dinky little cerebellum, and same thing on MR here, right? So they can be very hypoplastic because it's basically an acquired insult as they're developing. You can even have hypoplasia, dysplasia, and cerebellar clefts, right? So these were basically areas of injury, of hemorrhage, and then the cerebellum, which actually develops quite a bit postnatally in the first like 2 or 3 years of life, will foliate abnormally around these areas of acquired injury. Okay, so moving on to term brain injury. So the physiology here, so again, there's that primary, secondary, tertiary insult, but now it's kind of like directly related to the delivery, right? So before, right, the preterm, like some of that stuff we couldn't control because it might have been endogenous or the birth had to happen anyway. But with the term, it's basically like you have some kind of insult at the time of birth, around the time of birth, the difficult delivery usually. So we're assuming that insult happened pretty much, at that time. So that initial insult could have been hypoxic and or ischemic, right? It could have been the baby didn't get enough, good breaths, placental abruption, the cord, nuchal cord, anemia, right? Maternal or fetal, right? So lots of different etiologies, placental, thromboemboli. But it's not just that primary insult, right? The secondary energy failure. So this initial insult actually induces a whole metabolic pro-inflammatory cascade, and that causes additional injury on top of the primary insult. And the brain essentially fails to autoregulate. They're newborns, right? So they don't have the most mature cerebral autoregulation. And so in many times you can actually get a rebound hyperperfusion. So initially you've got low flow, right? From that initial HIE, and then HII, and then the brain will respond and maybe overcorrect, right? And so basically more blood flow comes in, but that actually leads to all this like free radicals and apoptosis and all sorts of negative kind of feedback loops that lead to essentially a lot more injury than just the initial insult. And then long term, right, months to years, you can have chronic ongoing injury from this process. So we want to kind of blunt that. And so the really only scientifically proven There are a number of adjuvants you can do, but they don't necessarily provide added. They may decrease hospital stay, but the overall outcomes don't really change on top of this therapeutic hypothermia. So the idea is that there's this window for the secondary energy failure, the first 6 hours after the birth, that you can actually blunt this response. And how do you do that? You cool the baby down, right? From like 36, 37, you cool them down to 33, 34 degrees Celsius for 3 days. And so you blunt that like hyperperfusion response, right? So that you're not delivering the free radicals and all this blood and inflammation to the already damaged brain. So you minimize that, essentially that secondary energy failure. And then after that, you gradually rewarm them back to normal temperature. And so because most MRI most cooling systems are not MRI compatible, this limits a lot of centers from doing the earlier imaging. But as I said, right, the immediate imaging is actually not as helpful as, like 3 to 5 days out. So usually after rewarming and stabilization, so, around day 4, if you're really on the ball, or maybe 5 to 7, if it takes some time, is when you see the majority of post-cooling HIE infants at most centers. And that's what I think we're going to show the most examples of. So there's this little, the Vanilla Ice, I think, was hot when I was growing up, so I'm dating myself now, but he had a song, Ice Ice Baby. But in the modern day, it probably is more useful to apply to this therapeutic hypothermia. So basically, they just wrap them in a blanket, right, and they cool them, and they pass the cooling fluid constantly through their body and also their head. Okay, so term brain imaging. There are multiple patterns described. So it depends on the duration and severity of the imaging. So you might have just like a few little, embolic things or whatever, right? So a little punctate injury. But the two most common are the watershed and the central patterns. So watershed is just like adults, right? It's between like ACA, MCA, PCA, or the internal, like the recurrent artery of Hübner and the, lenticular striates and whatnot, posterior choroidal. So those are like more border zone, mostly white matter kind of pattern. And that's what you see with your partial asphyxia, right? So like not total, but like partial, like usually shorter, but could be prolonged, but still like they had some oxygen, but it was reduced, right? And the central pattern, that's when you have like severe, right? So if you have like a complete anoxia, severe, prolonged, right? Then now the most metabolically active structures that are selectively vulnerable, right? The basal ganglion, thalami, the corticospinal tracts, the hippocampi, right? Those the ones that require the most oxygen and blood flow are going to be selectively hit because you have a complete anoxic situation. There's also infrantatorial injury, which is usually underestimated, and that's typically seen with advanced cases. And then you could have just diffuse or global injury. Okay, so timing-wise, right, just like in adult stroke, right, the diffusion will peak, usually like 2 to 3 days after, but anywhere from 1 to 4. As you get toward a week, right, you start to have pseudonormalization because the restricted diffusion in the swollen, dying cell membranes, the cell membranes lyse, so they release the edema into the interstitial space, and so you get that pseudonormalization of the ADC. So then after that, you can't really use this. So you can use the other things, like I mentioned, the T1, that dysmyelination on the watery brain background, that T1 hyperintensity is helpful. Often edema on top of an already watery brain is hard to appreciate. So it's pretty hard in many cases to see the T2 unless it's in a myelinated area like the plix. So that's usually more helpful late when you start to see like the encephalomalacia or the gliosis or whatever. So it starts to present more in the late period. But you can see it's very dependent on kind of physiology and timing. And then you can also do perfusion to look at that hyperperfusion response and metabolism. Okay, so HIE ultrasounds can have a variety of appearances, right? So here's some kind of, you see that gray-white interface is kind of blurred and you've got slit ventricles. So this is a diffusely edematous brain, but the location's pretty good because we're now term, right? Here's one of the central injuries, so very echogenic basal ganglia compared to like the white matter. And then here's another one where you actually have almost like a super scan. So like you have diffuse kind of white matter injury here. And then it's actually kind of exaggerated contrast with the more edematous gray matter. So you can have either decreased or increased contrast, but both are abnormal, right? And obviously you have to correct for ultrasound artifacts and gain and things. But again, like I think the clinical picture and then being able to really look at that gray-white distinction and so forth is helpful. Okay, so watershed injury, just like adults, right? So these kind of like ACA, MCA, PCA border zones, right? So the cortex, the white matter kind of paralleling the lateral ventricles here, restricted diffusion. You can see that the T2 is sort of appreciable, edema on top of an already watery brain, but it's not as easy to appreciate. So it's all about timing, right? And then late, so this is called eulogyria. So the medullary arteries are penetrating in to these kind of like deep sulci, and so it's kind of a watershed area if you're getting that low flow from cerebral artery. So basically, you get the selective kind of injury to the deep sulci with relative span of surface gyri. So it's like Latin for mushroom gyri. And so we're not talking like your American mushrooms. It's like not the straw mushrooms. It's like those Asian oyster mushrooms that have like really long stems and like tiny little tops. So that's what this eulogyria is. And this is a risk factor for seizures, for example. So you can see the border zone appearance on follow-up can be bilateral, but it can also often be asymmetric, right? So all of these cases have some level of asymmetry, but there is actually bilateral involvement. Watershed. And this just shows you that, although watershed injury is usually partial hypoxia, if it's prolonged, you actually have pretty severe sequelae. Okay, the central injury here. So this is the ADC, and you're seeing the restriction in these critical areas, right? High flow areas. So the corticospinal tracts, the basal ganglia. Classically, the areas that are selectively vulnerable in the term infant are going to be the posterior putamina right here, and then the ventrolateral thalami. So like these part of the thalami. So when you see that pattern, that's pretty specific for term HIE. And so here, this is a little tricky, but see the plics, they're a little bit faded. You're not seeing that T2 darkness for like a third to a half of it. It's kind of blurred out. There's maybe a little bit too much edema here. And then the ventrolateral thalami and the posterior putamen are actually a bit too T1 bright. So they're approaching the level of the plics, right? So something's not quite right in this whole central area. And then the ASL perfusion shows that we have like essentially a reactive hyperperfusion in those same injured areas, because basically they had the ischemia, now they're trying to rebound, but you see that they're actually stealing blood from the rest of the brain. The rest of the brain has pretty slow flow, and you have excessive perfusion to these injured areas. So that's that secondary energy failure, and it steals from the rest of the brain. And that's what we're trying to blunt with the cooling. So late findings. So here you see the cystic degeneration. So now like very, very bright posterior putamina and ventrolateral thalami with some cystic degeneration, very specific for neonatal HIE. And then here, this is older patient, but you see again that posterior putamina, ventrolateral thalami. So if you see this in an adult or an older child or whatever, and there's no history, you can call it, right? Because nothing else does this. And you can have asymmetric, right? So hemiplegia. You can have asymmetric central injury as well. So this person, right hemisphere involvement, they're going to have more left-sided symptoms. Okay, you can have large artery infarcts in term babies. It's not too common, not like adults, right, who have strokes all the time. But again, on the MCA stroke, on the ultrasound, restricted diffusion, edema, again, edema on top of a watery brain can be hard to see if it's more subtle. Interestingly, we usually don't find a clot, right? Like there's nothing for neural IR to do. It's usually the theory is that maybe there's some placental emboli, they kind of like flicked off and occluded, and then they kind of cleared out. So we usually don't find the actual clot, but you see there's restricted diffusion, but on the ASL, there's actually a luxury perfusion, and that MC is actually more hyperemic. So again, that's that secondary energy failure. So that's flooding the area with free radicals and causing additional injury on top of the original ischemia. And so again, in the late phase, you can get, porencephaly and eulogyria in those MC distributions. And so again, if you're seeing eulogyria, that's quite specific, that pattern, those mushroom gyri or cystic porencephaly. It means that they had a pretty early insult, not necessarily perinatal, but at least in the, first 1 max 2 years of life, right? When they didn't have mature astrocytes. So you can call it, this is not an adult MCA infarct, but this is definitely, even if you had no priors, you'd know this was earlier in life. And then global injury. These are tricky, right? Because here are some cases where I think they were outside the hypothermic window, like they got transferred in. It was more than 6 hours, so there was no point in starting the cooling. But you do see there's some restricted diffusion centrally, but there's some little spots peripherally too. This is a little too edematous, and then you're losing the plics. You're getting that bright basal ganglia. Too much edema here. So on follow-up, it's actually bloomed, right? So this was like 1 or 2 days. This was 5 days. And so you see that doing it too early, right? Doing the imaging too early can actually really underestimate the degree of end-stage injury. So here, yes, there's central pattern, but there's really diffusion restriction, profound basal ganglia, and really diffuse edema. You lose that gray-white distinction. Here's another example with ASL. So again, you see some central restriction, but it's a little too edematous out here as well. So it's really both central and peripheral patterns. You see that rebound hyperperfusion of the injured basal ganglia, and then it's stealing from the surrounding brain. You're losing the plics. And then here, so, at day 4 or 5, right, you have profound bloom. So the entire brain is restricted. The perfusion actually is more consistent between the two. So it's been a better prognostic factor, right? So you're still getting a ton of rebound hyperperfusion, right? And then in the end stage, right, you essentially have this like cystic HIE, right? Very swollen, and it all shrinks down. Okay, so last is the special cases. So these are things like that they're kind of slam dunk if you see them, but you have to know that they exist. All right, so hemorrhage, right? So normal birth, they're going through the birth canal. It's okay to have a little bit of subdural/intradural blood products, right? I mean, who wouldn't after squeezing your head around? But it should be like relatively little, and it should resorb, maybe in the first like few weeks or month after birth. Okay, delivery assist. So vacuum forceps, right? These things can be pretty traumatic, even sometimes a C-section if they're like yanking the head. And so you can have subarachnoid, subdural. You can also have something called subpial hemorrhage. So there's this beneath the pia mater, again, that the blood-brain barrier is immature in neonates, so they don't have their glia limitans. And so there's this potential space. And so you see this kind of triangular collections. And subarachnoid would just layer, right, along multiple sulci gyri and not push on the parenchyma. But these actually create mass effect because they're trapped, right, kind of like between 1 or 2 gyri and sulci, and so they create ischemia. Classically, they're in the temporoparietal regions, but they can be anywhere. So that's subpial hemorrhage. Most newborns get vitamin K injection in their thigh within 6 hours of birth to prevent this very thing. So this family declined the injection, and so the kid couldn't produce clotting factors, so they presented with a lot of like subarachnoid, subdural, interventricular hemorrhage. And then abusive head trauma. So here we have a stellate multidirectional fracture. We have, actual cortical vein thrombosis and kinking. And then they can have these asymmetric ischemias. Some people think it's like from the shaking and maybe like the strangulation of one carotid and so forth. Okay, scalp collections. It's normal to have caput succedaneum. So that's basically as you go through the birth canal, some of that fluid gets forced into the connective tissue and it resolves. It's kind of along the vertex here. There's something called delayed subaponeurotic collections of infancy. So these are not present at birth. They come up like a couple weeks to like maybe 4+ weeks after, and they're kind of boggy and fluctuant. And so the idea is that maybe like there's some impaired glymphatic or lymphatic drainage and it's often associated with more difficult deliveries. But these also will self-resolve, and they're kind of like fluctuant. And most importantly, they're delayed. They're not present at birth, and they're simple collections. Cephalohematoma, so this one is actually limited by sutures because it's actually periosteum. You can see that there's some mineralization of this. It's actually that outer layer of the periosteum being uplifted, and the hemorrhage is going into that space, right? And so these can actually ossify and become part of the skull and just become an asymmetry. But again, you see that thin mineralized layer of periosteum, and they basically are delimited by sutures. So coronal, squamosal suture, sagittal suture, they do not go beyond. Subgalic hematomas, just like in adults, right, require an actual skull fracture, right? So this kid had forceps delivery, and so has a lot of skull fractures, has a lot of subdural blood products, venous sinus injury, and then like a lot of subgaleal blood. Other scalp collections, you can actually have meningoceles. You can actually have herniated brain, right? Not just, it's like a dural bone defect and herniated brain. So these can be anterior or sincipital, like frontoethmoidal nasal. We see those more in the Asian population. The posterior ones are more North America, Europe. So you can have atretic cephalocele in the parietal region most commonly. And so these are actually like, they were meningoceles and they kind of closed down. And so you just have a little residual fibrovascular stalk, but a lot of times they're no longer communicating. They're kind of functionally closed, so they can just kind of resect this thing. And so they have a little bit of, kind of everything's converging toward that area, but essentially it functionally closed off. And kind of occipital ones, this is actually a Chiari3, right? So you have a cervical occipital encephalocele. You also have some interhemispheric holoprosencephaly. Superior vertex ones are pretty rare. You can sometimes see that with amniotic band syndrome. And then basal encephalocele, so the sphenoid ones, those are the frontonasal dysplasias or morning glory syndrome. So they can have excavated optic discs, cleft palate, duplicated odontoid and pituitary, oral teratomas, hypertelorism, and so forth and so on. So a whole like a kind of facial mid-face fusion syndrome. Okay, vascular lesions. So just like in adults, right, you can have cortical and medullary vein thrombosis, but neonates are more predisposed to prothrombotic conditions from the birth, from sepsis, from hypoxia, ischemia, all of these things. So you really want to make sure that this is a high level suspicion, because I think this case was called trauma by an adult radiologist, right? And it's like, yes, there is diffuse hypoxia and there's a lot of peripheral, but I mean, there aren't any subdurals, right? And it's like, what is this? So basically there was diffuse venous sinus thrombosis, and then you had secondary arterialization, because if you get the impaired venous outflow over time, the pressures build up, and then you get little petechial hemorrhages, right? The capillaries rupture, and then the pressures get so high for venous outflow that you start to get secondary arterialization. So there's no, large artery distribution because the entire brain is infarcting, right, from a long-standing venous thrombosis. So very important to remember this diagnosis. And the medullary veins can also be congested and immature. And so you can see, again, that T1 shortening, kind of linear radiation, engorgement, thrombosis. And so this can also give you kind of like a white matter injury-like pattern. But the key is that you actually have a bunch of congested medullary veins through that whole area and very linear. Vein and Galen malformations, this essentially AV shunting, high flow shunting, right, through the median prosencephalic vein. They can have this turbulent yin-yang flow, lots of, choroidal or mural feeders and ischemia of the brain parenchyma. And this is a good one to know, the collagen 4A mutations. They can cause neonatal or even antenatal hemorrhagic porencephaly. Essentially, it's the collagen 4 in the vessel walls can give you hemorrhagic strokes throughout life, right? So if you see like a fetal MRI or a neonate with a bunch of like hemorrhagic, porencephalic cysts, right, you really have to invoke this diagnosis. Infection, so congenital CMV, we've all seen, it depends on how early they were infected. If it was early, they can actually have severe migrational abnormalities. They can have germinal cysts, particularly in the anterior temporal regions. They can have migrational anomalies, paraventricular calcifications. Zika, especially in the first trimester, could give you very severe, volume loss, migrational abnormalities, scalp rugae. So this is all like very, early developmental acquired condition. Parvovirus, this is a good one to know. It has a sunburst pattern. There's a few other viruses can do this, but that's to relate to the inflammatory microglia. And so they can have this kind of radiating restricted diffusion through their paraventricular regions and some of the white matter tracts, basal ganglia. And then other, bacterial conditions can give you abscess formation, hemorrhagic meningitis, and so forth. Congenital malformations. So we all know Chiari-2, right? The myelocele, myelomeningocele. It basically causes a prenatal CSF leak. So the tonsils come down, but also it affects the cortical folding and the migration, because you have this essentially developmental CSF leak. Polymicrogyria in an unmyelinated child, it can be a little bit hard to diagnose, but again, this is a very broad, kind of thickened, irregular fissure, Sylvian fissure. And so even if you're not doing a sedated exam, right, just to see some of these 2D images to realize that, there's something not quite right about this Sylvian fissure. Holoprosencephaly, different levels of, frontal lobe malrotation and fusion, not a subtle diagnosis. Tubulinopathy, if you see some crazy pan-migrational type, supra-infiltratorial, asymmetric, those are often mutations of microtubules, because those affect the actual radioglial fibers along which the neuroglial progenitors migrate. So again, medical genetics and or kind of neurology assessment can be helpful for these. Neurocutaneous disorders are marked by their cutaneous manifestations, as Sturge-Weber with this, blush over the eyebrow here. And so actually, this is the normal side, right? This is the normally myelinated corticospinal tract. This side is accelerated, right? So you have way more myelination, T1 shortening, T2 dark than you should in a newborn. And you see that there's these dysplastic veins, right? So these enhance, it's essentially a venous malformation. And so the brain can't drain in the early stages. So it actually has a lot of blood pooling and it accelerates myelination. It's only later on when those dysplastic, cortical veins cannot drain the blood, you start to get venous ischemia. But in the very early phase, this is actually what Sturge-Weber looks like. Tuber sclerosis, adenoma sebaceum, right? So you can have a bunch of tubers, which are essentially just migrational anomalies. So again, unmyelinated watery brain. So you actually have the inverse signal, right? It's actually T1 bright, T2 dark. Once the patient myelinates, they look the opposite, right? They look actually T1 dark and T2 bright, the tubers, but this is what they look like in a neonate. And the calcification is really a late finding, so usually you only get a very little calcification early on. This is a stomatic overgrowth, so they can have capillary malformations, polydactyly, polymicrogyria, and so this is all PIK3CA pathway. And then nerve cutaneous melanosis, so proliferation of melanocytes in the skin, central nervous system. Again, this is best done on the neonatal scan because as a patient myelinates, these T1 deposits start to blur with the myelinating brain. Inborn metabolic disorders. So the key here really is like working with the newborn screening or the pediatrician to see what the suspicion is, because they all have symmetric restricted diffusion, right? Basal ganglia, maybe some white matter stuff. And then they have supposedly characteristic, spectroscopic signatures. But unless you have the clinical suspicion and the lab test, it's going to be really hard to like look for some very subtle peak. But once you have the clinical suspicion and you can say, okay, putting all this together, right? This is an inborn error of metabolism. And typically these patients, sometimes they can mimic HIE, but they had a normal delivery and then suddenly they just crump, at some point after birth. Maybe they had like a little illness or a little minor trauma, and then they just like decompensate rapidly. That's usually the history for metabolic disorders. Acquired metabolic, so hypoglycemia, posterior circulation. It's probably like a press-like phenomenon, right? So you have a poor autoregulation. You have low glucose, and it tries to like push the flow here, but you end up getting a kind of posterior, often visual cortical injury. Unconjugated bilirubin, right, jaundiced infant, right, will be particularly neurotoxic to globus pallidus and terna, and then in the chronic stage, you'll see atrophy. Hyperammonemia, so some of these metabolic acidoses, right, can selectively injure the periorlandic and insular regions and the basal ganglia. And then some cases of osmotic demyelination, which actually this patient had HIE, and then on top of that had osmotic dysregulation because of the pituitary hypothalamic axis. And toxic conditions, so again, just, kids put stuff in their mouths, right? So glipizide poisoning, this was essentially like a diffuse cerebral edema. Vigabatrin is used for infantile spasms, and so that's a GABA analog, so you can actually get some reversible injury to the deep gray nuclei. Withdrawal from maternal opioids can give you a number of features. And then even the synthetic opioids, like because they don't clear well in infants, can give you quite a bit of injury if you accidentally overdose. And then finally, tumors. So neonatal tumors are rare. A lot of them are these desmoplastic gangliomas, which are WHO grade 1. So they have some cystic components and peripheral nodular components, but they're pretty indolent, even though they look bad. The hemispheric gliomas are high grade, and this is the infant type. So these have been recently described. So these are pretty aggressive. And then teratoma, especially immature ones, don't have a good prognosis. But again, this is kind of, germ cell, restricted diffusion, calcification. All right, so that's everything. In conclusion, neonatal brain physiology is very dependent on clinical background. So always look at the notes and try to correlate when you're reporting a case. There are characteristic imaging patterns with preterm and term birth injury that we've described. So recognizing and being aware of those is very important. And then any unusual features, all those kind of more rare cases we just went over should prompt a more detailed workup.